Assalamu alaikum. Welcome everyone on board. Yesterday, we were on this MCQ about coarctation of aorta, and I was just trying to say a few words about fetal circulation, and my mind just closed, I think. So, from the same place, we will start. Actually, fetal circulation is a little different in the adult circulation, and even because in the it's having the blood flow from the placenta through the umbilical vein, and then pass through the liver, and then reach uh, the right side of heart and the right atrium. Uh, just a second, please. And here there will be two pathways. One will be which is coming from the inferior vena cava. This will go towards the blood coming from the superior vena cava and inferior vena cava. They will have different pathways because this blood will be oxygenated coming from the liver side. So it will be going from the uh, right atrium to the preferably to the root through right atrium to left atrium, and then left atrium to left ventricle, and then aorta, and uh, it goes to the upper cervical, this right cervical, thoracocervical trunk. So, so right side, so that will be oxygenated, more oxygenated blood. Okay, and then the blood which is coming from the upper half of the body, which is less oxygenated, like blue blood, that is coming from right atrium to the right ventricle, and then right ventricle to this pulmonary artery, and then from the pulmonary artery, because the lungs are there is no blood flow going to the lungs, so there is something which is ductus arteriosus, and ductus arteriosus is the one which is bypassing the lungs, and it is joining the aorta. Okay, so what is this is because that's why the right sided circulation, that is right radial artery, is the one which is accurate in saturation and like even in blood pressure reading, because after that, if the blood which is coming is having low oxygenation, okay, because it's coming from this ductus arteriosus, and this is going towards the lower half of the body. Okay, that is how the fetal circulation works. So that was the point which was here in this MCQ, that there was coarctation of aorta. So there was signs of poor circulation with as this baby presented with lethargy and high blood pressure, sorry, tachypneic, tachycardic, and low blood pressure, low signs of low capillary, like poor circulation. Okay, and weak femoral pulses. So that was the scenario of in this one. And the answer to this question was this prostaglandin E2, because it will maintain the this rectus arteriosus. Okay, so it will keep the circulation through the uh, this this. I'm sorry, actually, I was disconnected. Just a second, please. Okay, so in this scenario, the goals are to have good fluid resuscitation, and of course, the patient will be intubated, Can you hear me? Is my voice audible?
Yes.
Yes,
Yes,
sir.
sir.
Yes. So, uh, in coarctation of aorta, which is a congenital narrowing of the descending thoracic aorta at or near the connection of ductus arteriosus. That's what I was telling you. Okay. So it is second most common congenital heart disease, constituting 8% of heart anomalies. The most dramatic presentation of aortic coarctation occurs in the neonate who is dependent on a PDA. So if it is not there, because now, because the aorta is not patent, okay? So now the blood is bypassing in that before it was right to left circulation, now it is left to right circulation. So that is why prostaglandins are given to keep it circulation patent. Okay. After a relatively asymptomatic period of days to week, the PDA will close and immediately limit blood flow distal to the coarctation. The ensuing left ventricular failure and systemic hyperperfusion manifest as respiratory distress, cold and pale, lower extremities, markedly decrease or absent pulse, metabolic and respiratory acidosis. So actually, this was the question in this scenario. Okay. So the next question is a 5-year-old, 20 kg old child um, of of a district hospital with 15% burn from scalding to neck, chest, abdomen, and right upper limb, having already received 20 ml per kg Hartmann's and 20 microgram per kg morphine for analgesia. Um, so it's a scenario of burn. It is 4 hours since the time of injury. On the examination, child appears comfortable with a heart rate of 110, blood pressure 120 by 80, respiratory rate 22, SpO2 99%. So it is scalding to neck, chest, abdomen, and right upper limb. So what is the significance of um, because this question I think is on the basis of referral to the tertiary care for to the burn unit, you can say. Um, so what is the presence? What is the problem in chest and chest burn? Can anyone tell if there is
Sir,
chest burn?
patient could have like inhalational injury
It
if it's
can lead
chest
to
and neck.
contractures,
Contractures and
which
you
will
can
hamper.
yes, yeah, inhalational injury is another thing. But if it is that one, that maybe in the scenario they will be telling something about closed cavity, closed area burn, or something else. So in this scenario, most probably it's not that. And I think if it is all around the chest, it can restrict the chest movement as soon as that this restriction occur. Okay. So let's see what is that how they have calculated 110 ml per hour. Usually, what is the how much fluid we should give? First of
So
all,
it's a Parkland formula, 4
okay.
ml per kg per percent area of burn.
So it is 15% burn. So 20 into 15 into 4. So how much it is?
Sir,
How they have calculated 110?
1,200.
Yes, it is around because it is if someone multiply, it is around. So if it is uh, just a second, please.
It is almost 1200 ml.
Yes. Yes. Okay. So out of that, 800 need to be given in first 8 hours. So that's why they have made it around 110 ml per hour. Okay. So you should be just quickly. Okay. So because the answer now we have seen already, let's see the other options first. Give antibiotic prophylaxis IV Hartmann's at 110, admit for further observation. So this is not admission. It needs to be because the scenario in which they have given is general hospital. So this needs specialized hospital. So this is number intubate and ventilate IV, refer to tertiary care for. There is no indication for intubation at the moment. So these two options finish. Then IV Hartmann's refer to tertiary. This is less. Okay. And again, so the answer is very easy that we have to start the fluid and have to refer. So this on the basis of this point, they have choose the A option. Okay. So you see, uh, first of all, I just want to ask Ishan, did you pass?
Sir, I didn't give the exam, sir.
Okay, so I was thinking that you have passed. Anyways, welcome back. So just keep in touch. It will be a good revision for you. Um,
Yes.
keep in touch. Okay.
Yeah.
So anyway, so just keep trying to answer. Although we are discussing MCQ, but the same knowledge is there in the Viva. So I hope it will help you. Okay.
Yes.
uh, because it has the same points which we discussed in the our recently when we did the burn. So the same thing that how much percentage of the burn, what is the area of the burn, okay, and if there is any involvement of respiratory system, edema will occur, and we have to maintain the airway early. Otherwise, when airway edema occurs, it will be difficult to maintain the airway. Okay, so what they have written here. Okay, so resuscitation, analgesia, sedation, intensive management, adequate early fluid resuscitation. And we discussed about this thing before as well. What about what is the problem in giving albumin? Sorry, in giving polites early in the resuscitation? Because there will be leaky capillaries, so they can come out of the circulation. It will not remain in the circulation. It actually will cause more edema. So that is one of the reason. Okay, so actually there will be, we will just have a look that what is the requirement if it is for referral. So fill thickness burn exceeding 5%, partial thickness burn exceeding 10%, inhalational burns or burn to airway, face, hands, feet, perineum. Antibiotics are only indicated in suspected or confirmed infection, not for prophylaxis. Okay, so that is okay. So the next question. 57-year-old with history of facial pain that occurs sudden episodes of a few minutes and often only affect right cheek. It starts with a sharp electric shock, which then becomes ache before it abruptly disappears. Treatment with carbamazepine was commenced, 100 milligram BD this week, and this has provided only modest relief. So, by the way, what is this condition?
Yes.
Trigeminal
Trigeminal.
Neuralgia, sir.
So first of all, if you can just say that this is a neuropathic pain, and most probably it is trigeminal neuralgia. If it is involving only one side and any specific dermatome, can it be something else? Yes, Zishan.
Sir, the differential diagnosis can lead to post-herpetic neuralgia also and
Yes.
neuropathic pain also.
Neuropathic, actually, this trigeminal neuralgia is neuropathic pain. Okay, so just can you revise? Just we will go to the answer, but do you remember what other medications we use for neuropathic pain? One is this carbamazepine group, tricyclic antidepressant,
Sir, first, I think we should increase carbamazepine dose. It can be increased up to 200 milligram BD. And
Mhm.
after that, sir, your lamotrigine is also given. If carbamazepine is a patient is hypersensitive or allergic to carbamazepine, then
Okay.
lamotrigine is given. And for neuropathic pain, we give gabapentin and other anti-epileptic drugs, anti-psychotic drugs,
Yes.
amitriptyline,
By the way, that is not psychotic drugs. That is
and also
antidepressants. Antidepressant, tricyclic antidepressant, SSRI,
yes, sir,
SNRI. There are
antidepressant.
three different types. One is TCA, one is SSRI, and one is SNRI. Okay. And then another thing is that there will be certain other surgical options as well. This carbamazepine is what? Is which group?
Sir, it is a sodium channel blockers.
Yes, the sodium channel, but it is what? It is broadly grouped as anti-epileptic.
Anti-epileptic, sir.
I check.
Anti-epileptic. Okay. So this is trigeminal neuralgia. As Vajiha mentioned, we have to increase the dose. So it's a paroxysmal episodes of intense, severe, lancinating facial pain. Same words you can use in your Viva as well. Okay, a typical episode lasts seconds to minutes and starts and ends abruptly. Insidiously occurred and insidiously gone. The pain itself is often described like electric shocks or stabbing, and almost always affects just one side of the face, frequently the right. Triggers are usually trivial and may include washing the face, chewing the food, brushing teeth, vibrations, or exposure to wind, and even certain sounds. It's not written here, but it is through sharp sounds as well. Maxillary or mandibular distribution of trigeminal nerve are most commonly affected. Attacks vary significantly in frequency and may range from one or two to several hundred per day. Over time, trigeminal neuralgia follows a relapsing and remitting course. A relapse may last days or months, and remission may be as long as for years. Okay, occur more frequently in females. The peak incidence is 50. These are just a matter of some information. 80% of cases there is compression of trigeminal ganglion, so most commonly due to aberrant arterial or venous loop. Other causes may include multiple sclerosis. Okay, multiple sclerosis, Chiari malformations, tumors such as schwannomas or meningiomas or pontine lesions. Diagnosis is purely clinical. Differential diagnosis includes post-herpetic neuralgia, TM joint dysfunction. So this is for your exam viva point of view as well as in the MCQ. So you should be knowing each special point. Okay. In the differential diagnosis of headache, you can have. We will just try to have a look because all these can have mimicking effects. Okay. MRI may be helpful to exclude other causes of pain if the diagnosis is less obvious. It is more sensitive. It is a more sensitive available for the diagnosis of multiple sclerosis and useful in visualizing the posterior fossa where tumors associated with trigeminal neuralgia like schwannomas or many. So MRI is not to diagnose. Actually, it's to rule out other serious causes. Okay. While trigeminal neuralgia may go into remission spontaneously, the symptoms are usually severe enough to warrant treatment. Treatment option may be medical or surgical. Drug of choice is carbamazepine, so effective that lack of response, some authors suggest, should prompt reconsideration of the diagnosis. It's so effective that if it does not work, it means there may be something else. That's the word. Okay. Uh, it is keto derivative oxycarbazepine. It's keto derivative oxycarbazepine can be used with equal effect and with fewer unwanted effects. Whenever you are reading any medication, you should be knowing the mechanism of action. You should be knowing the side effects, especially correlation with the anesthesia. That is the rule. So, 100 milligram BD, and then it may be increased to 200 milligram, and lamotrigine or baclofen. may also be used if it's contraindicated or poorly tolerated. Surgical options include microvascular decompression, rhizotomy, stereotactic radiosurgery, but due to invasive nature of these interventions, they are reserved for refractory cases. In this patient, therefore, the most appropriate intervention at this stage would be to increase the dose of carbamazepine. So, what else will be? Increase the dose. Micro is also amitriptyline may be added, lamotrigine may be used, and actually cognitive behavioral therapy should be used. So, when you are preparing for this MCQ, if you are reading about it, read each and everything. What is microvascular decompression? What is cognitive behavioral therapy? What is amitriptyline? What is lamotrigine? When you, if you, because these explanations are not written here, so you just have to do Google. What is lamotrigine? What is the mechanism of action? What is the side effects? Similarly, few words, one or two words about cognitive behavioral therapy. Okay, microvascular decompression, how it works. Similarly, what they have written, rhizotomy. Like you should explore the words. What is stereotactic surgery? As they were used in awake craniotomy as well. Okay, so these are few important things which you can extract from MCQs. Okay, you are presented with a 43-year-old woman who had mastectomy. Okay, 7 years ago, following new adjuvant radiotherapy and chemotherapy for left-sided breast cancer. She is currently taking hormonal therapy and has had pain over the left chest wall for past 2 years. So actually, so many information you can think about it. Mastectomy. This patient is a candidate for which sort of pain? Zishan or Wajiha or anyone? What sort of pain can occur in this patient specifically? Phantom limb pain. Okay. Phantom limb pain can occur in this patient. One thing. Then, what are the effects of radiotherapy and chemotherapy? Like it can
Chronic
cause
post-surgical pain.
Sorry, again, please.
Chronic post-surgical pain.
Yes, chronic post-surgical pain also. CPSP. And actually, we have all people from Pakistan, we have a special association with this disease, because the name of our college is CPSP, College of Physician Surgeons Pakistan. But actually, it's not CPSP for majority people, it's chronic post-surgical pain. And actually, it is. So it's a special name for our country actually. CPSP is not College of Physician Surgeons, it's chronic post-surgical pain. So okay, so hormone therapy and also cancer itself, and especially hormone therapy, this patient is at risk of embolism. So these things should be, of course, in this question they have not asked these things, but whenever you are reading such things, such scenarios, you should just brainstorm yourself. Okay, there may be reoccurrence, there may be chronic post-surgical pain, there may be neuropathic pain, there may be phantom limb pain, and this patient has taken hormone therapy. So these are the things. Which of the following is most corrected regarding this patient's chest wall pain? Okay. Urgent referral for investigation of reoccurrence. This is one. Phantom limb pain is rare in post mastectomy patients. So this is wrong. Long term
क्लास में मैंने बहुत किया था अभी एक और
long
ब्रांड
term
है चेक करो कौन सी
long term opioids should be commenced. Again, long term opioid therapy is not a very nice thing. Should be commenced. Brachial plexus pathology is the likely cause. The pain will usually respond to anticonvulsants. So let's see what because uh, brachial plexus pathology, I am not sure about it because
So
opioids
ये
is not.
anticonvulsant seem
Yes,
true. Anticonvulsant for chronic pain.
yeah, because in this one, urgent referral for investigation of recurrence is needed. This is also true, but usually it's not related to pain. Okay. Uh, Phantom limb pain is common. Long-term opioid is not good. Brachial plexus pathology is can be there, but not the likely cause. Let's see what is the answer in the key. Okay. So is an increasingly common phenomena. Its exact etiology is unknown. Most of these pains are benign, and local cancer's recurrence is unlikely at 2 years. Okay. Uh, the nature of the pain is mixed, neuropathic and nociceptive, but phantom limb can occur in 22 to 64% of post-maximum patients. It is appropriate to use anticonvulsants such as gabapentin, pregabalin to treat such pains. Use of long-term opioids is not recommended as tolerance usually develops and long-term hormonal and immune suppression is increasingly recognized. Uh, although plexopathy can cause chest wall pain, these patients often have arm symptoms rather than pure chest wall pain. Okay. Also, brachial plexopathy is usually only found if the cancer has reoccurred, while the 2 years history would make it unlikely in this circumstance. Therefore, the most appropriate statement is that the patient's pain will probably respond to anticonvulsants. Again, I tell you that the STEM will tell you. They have asked you not about the cancer. They have asked you which of the following is most correct regarding the patient chest wall pain. They are not concentrating mainly on the reoccurrence. So because reoccurrence is also, this is statement is written wrongly, but usually phantom limb can also occur. So that's how you will. Okay. A 46 years old right-handed violinist present with a 3 months history of worsening severe pain in his right wrist, which commenced suddenly after a long performance in a concert. He has noticed the painful wrist going pale and cold at times, swelling occasionally. Sometimes it sweats and it has become stiff and difficult to use. It appears smaller than his left hand. So there is muscle wasting, there is autonomic problem. So there is like poor circulation, autonomic problem, there is swelling. So what happens that the nails of his right finger have become brittle and discolored. So everything is going towards the CRPS, I think. He admits being very distressed and anxious as he is no longer able to perform. Treatment with paracetamol and amitriptyline has been commenced. So what will be the next? Okay, so one, they have written pregabalin, acupuncture, patient education and psychological support, application of 5% lignopen patch, mirror therapy is not there. So actually, patient education and psychological support will be there, but you need to give something. Okay. Lignocaine patch will not work too much. I think the answer will be pregabalin. Let's see. Because education and psychological support should also be there, but which is first?
Such
Uh,
first step is patient education and rehabilitation. So it's correct, है ना?
so this is the topic of CRPS. Very difficult and stupid topic, I say. The same, when I read it, I thought that what is it? Because this question was asked in our Irish fellowship exam. Actually, the same Budapest criteria. This patient has developed symptoms and sign of CRPS. Actually, in type 2, there is a definitive nerve injury. So here there is no definitive nerve injury, but it's a chronic injury which is lead to this phenomena. Chronic debilitating painful condition. It is uncommon and usually develops following an injury, but may occur spontaneously. It affects one or more limbs and typically demonstrate a collection of symptoms deprived as sensory, vasomotor, pseudomotor, trophic, and inflammatory. So they have told everything here in the scenario. Okay. So this patient has this vasomotor. There is swelling, which is because of inflammation. Okay. And so sensory, vasomotor, pseudomotor in the skin, and trophic and inflammatory. Pseudomotor is about sweating, but I've just forgot. What is pseudomotor?
Yes, sir. Sweating, sir.
Okay. So this Budapest criteria come, but does it say continuing pain which is disproportionate to the inciting event? Patient has at least one sign or in two or more categories. Patient has one symptom in three or more categories. No other diagnosis can better explain the sign and symptoms. Okay. So that is what is there. CRPS can be academically classified as type 1 and type 2, but does not influence subsequent management of prognosis. It's all the same. What is allodynia? The
Extreme pain
non
also, non-painful stimulus.
yes, non-painful. What is anesthesia dolorosa? The area where there is no sensation, there is pain. If I'm not wrong, hyperalgesia is increased pain sensation. Okay, so these are signs. Allodynia, hyperalgesia, changes in asymmetry, sweating as asymmetry, edema. So this is sensory. Vasomotor are changes asymmetry in skin color, temperature asymmetry. Okay, and pseudomotor as sweating asymmetry, edema, and motor changes like decrease range of movement, motor dysfunction. So symptoms will be hyperalgesia, changes in color, and it's so we have to choose one sign from two categories and one sign from three categories of symptoms. One symptom in three or more categories, one sign in two or more categories. That's why actually this is so confusing. I don't like this topic at all. But we don't have. Luckily, Alhamdulillah, I am passed. I don't need to read it again. So etiology is uncertain and thought to be multifactorial, as no one single theory fully explains. Current hypothesis is inflammatory process or altered neurological function. There may be association between the use of AC inhibitors and the development of CRPS. Regarding treatment, there is lack of robust evidence for CRPS, and most recommendations are derived and extrapolated from those of for other neuropathic pain condition. Early treatment may help prevent the development of some of the long-term sequelae, because if you develop early treatment, some of the debilitation may be decreased. In this scenario, the patient must be educated about the condition and fully involved in decision regarding his subsequent management. This will establish whether he will benefit from treatment such as mirror therapy, motor imagery, or CBT, cognitive behavior therapy. Physiotherapy and occupational therapy are both recommended early. Ensure patient understand condition and be involved in making informed decisions about their treatment, like information leaflets, sufficient time spent with patient and family allows. Then physical and vocational rehabilitation, physiotherapy, stretching, weight bearing, fine motor. So these are the things. Pain relief, medical or procedural options. Medical is amitriptyline, pregabalin, lignopigen patch, ketamine, steroids, spinal cord stimulation, and intravenous regional blocks. Sympathetic blocks also are used, I think. Psychological, both patient and family benefit from psychotherapy, significant psychological burden, CBT. You know, just cognitive behavioral therapy. Just few words about is a structured goal oriented type of talk therapy that helps patient learn how to identify and change destructive thought patterns. It is effective for a range of problems, including depression, anxiety disorder, alcohol, or drug use problems. Okay, so you even if you have few words about it, it will help. It is also for the treatment of post-traumatic stress disorder. Uh, Pharmacologically, there is lack of evidence for benefits of anti-neuropathic agents. Amitriptyline is the first line choice for neuropathic pain in journal, followed by pregabalin. And additionally, there is still limited evidence to support early use of acupuncture. Actually, there is no specific treatment, and you have to go in multiple directions. So I will just uh, show you some of the articles with reference to pain. And just a second, please. And if you are preparing this topic, you should even when we discuss, I had the same thoughts that actually there are some majority of the things which are common. Okay, so try to learn that the common things. Here there are article about CPSP. Okay, and so you should be knowing the factors which will lead to chronic post-surgical pain. Okay, and uncontrolled or not very controlled, and this acute pain will lead to it. And because this chart will give you the commonalities, so which surgery will have more chances. So percentage, not commonalities, I'm sorry, the incidence and how to prevent it. Good uh, multimodal analgesia, okay, will be, and that's why the gabapentin is also being used in uh, uh, preemptive analgesia also. Okay, so it is also a factor for reduction. So you can have a look here. This is for CRPS. Neuropathic pain we discussed about. You will find here for neuropathic pain in journal. This is a very good article. It's an old one, but it's a very nice one. Okay? So you can have a look here. Post-herpetic neuralgia, trigeminal neuralgia, and diabetic neuropathy, phantom limb pain. These are all, Wajiha, you were saying 2, 3 times neuropathic pain. So actually they are neuropathic pain. They are not separate. Okay. So
Yes, sir. Almost all these types are within
yes,
neuropathy.
and even I wanted to tell you one thing I forgot, that these are the general treatment here. Okay, here you will see. Uh, Next slide, please. Mhm. Okay. Yeah, here you will find the management. Okay, so pharmacological interventions the same. If you forget, these are the same. So TCA, SNRI, serotonin, norepinephrine. This is venlafaxine. Okay, and then SSRI, citalopram, paroxetine, anticonvulsants. In our practice, which we use is gabapentin and pregabalin. This sodium channels, this carbamazepine, lamotrigine. So these are all anticonvulsants. And then opioids. Opioids is not the first line. And then the topical treatment with lidocaine, capsaicin, ketamine in resistant cases if nothing is working. So you should just knowing, and almost in all neuropathic pain you can tell one by one. And the rest of the thing, nor pharmacological also. So in which cognitive therapies, as we discussed, hypnosis, meditation, and the TENS, the also role of this TENS and acupuncture will come. Okay. So if you learn these things, any one of the thing will be there. But for neuropathic pain, as we discussed, psychological therapy is equally important. Of course, in addition to all medical and surgical interventional we are doing. Okay. What else we discussed? Few articles. So I think there are 2, 3 pain uh, topic we discussed today. Again, yes, I forgot. Let me show you. Headache. Just a second. Headache. There wasn't. So all the people who are studying, please have friendship with articles. This will give you, and you don't need to the way I'm having a look at it. You just have to read in such way. You just go to here and read the key points. Then you read all the charts. A lot of information you will get from the charts, and then you can, according to the topic, you might need to have some more detailed discussion. But mainly, this is the way how you target. Okay, so differential diagnosis and like you see, tension, migraine, cluster headache, This is what we discussed with the trigeminal neuralgia as well. And when you will read about it, you will find certain uh, features which will differentiate, because this MCQ can come very commonly in the exam about differential diagnosis of headache. So this is a topic even in the in for your Viva, both Vajih and Zishan, it can ask. I don't have very good concept because unfortunately we are not doing pain. So whatever I remember in my heart, is I just try to say what is cluster headache. I don't know. I have so you can have a look here. This TM disorders, post-herpetic neuralgia, trigeminal neuralgia, persistent idiopathic facial pain. So, and then dental problems can present as a headache, eye problem, ear problem, okay, and even brain pathologies. So, all can come, and you just have to differentiate between various causes, okay. Uh, what else we had? Mm, Fetal circulation. What MCQs we discussed today? So this one, yes, burn. Let me show you burn as well. In burn, the more important points are quickly in burn, you should know the site, the extent, the nature, okay, whether it is chemical burn, inhalational burn, and then how much fluid you need to give. You have to prevent for infections. You have to give adequate fluid therapy. There may be chances of patient going in DIC. Pain is a big problem. Then concerns related to use of suxamethonium. Okay, patient will be coming for repeated procedures, and if you are talking about skin graft, so you need to have the concept that you have to have good perfusion, good pressures, but avoid using vasopressors. Okay, avoid having hypothermia. These will all cause problems in the graft. So these are main points you should be knowing about burn. And then they will ask further details. What are different formulas? What are we can just have. And in relation to smoke and inhalational burn, you should be knowing about carbon monoxide poisoning. So the question may be about carbon monoxide poisoning. What is the pathology? How it responds? And anyone, if any of them they know about it, so anyone else want to tell what is the role of hyperbaric oxygen? What is the role? In noon.com, would you like to say? Hamza, is it Hamza?
Yes, yes, sir. It's Hamza, sir.
Yes. So what is the role of hyperbaric oxygen? Do you know?
No,
Hyperbaric
sir. Sorry,
oxygen.
sir. I
Okay.
heard about this hyperbaric, but I couldn't explain in a good way, sir.
Okay, just
Like
try to.
concept नहीं है, sir.
I will ask you in yes no option. In the oxygen delivery uh, or oxygen content, one is dissolved oxygen, which is a minor proportion, and one is oxygen carried by hemoglobin. So, what do you think when we give hyperbaric? Does that effect dissolved or this attached? Only this. Try to answer. Like if we give hyperbaric oxygen, does it affect the oxygen carried by hemoglobin, or does it affect the dissolved oxygen? Think about it.
Sir, on dissolved oxygen.
No, no, you know about it. I wanted him to speak out, Vajia.
Okay, sir.
Anyways, now you have spoken.
Sir,
So
it
now can you
will
think
affect
why?
the.
Sorry.
Yes, sir. It's about the dissolved oxygen, sir. It
Okay,
will
so
affect the
because you
dissolved
see it
oxygen.
is with PO2. Okay, so when we give hyperbaric, it is affecting this part because carbon monoxide has too much affinity for this one uh, hemoglobin. Okay, so it will not let oxygen attach to the hemoglobin. Okay, so that's why we need to the role of hyperbaric therapy is in the dissolved oxygen. So this is, and yes, this was a MCQ in which they will asking. that what will be the reason for referral. You can have a look here. Okay. So actually they make a lot of questions from the guidelines and from the such things. Okay. Mm, so you can have different side. Even we discussed recently in detail about different types of burns and everything. So you can have a look. So the bottom line is that whenever you are reading any MCQ, try to explore what are the sideway movements or sideway things you need to do. Okay. So okay. So 30-year-old woman with chronic lower backache, this will be our last question, inshallah, is assessed in an outpatient clinic. She tells you that her pain has improved with exercise and local heat application, but she thinks about the pain, it seems to get worse. So regarding the gait control theory, this question is regarding gait control theory. Which of the following is most accurate? First of all, and now, Vajia, you tell what is gait control theory?
Sir, to be easily understanding, it's when one gate is open, the other gate is closed. Similarly, but when one sensation pathway will be stimulated, the other sensation pathway that is probably pain will be closed. So if we give stimulation other than pain to the sensation of pain, other than pain, then the sensation of pain is reduced.
Okay, so when we do this TENS or we rub, okay, when we even rub our hands or feet whenever it hurts, what fibers are stimulated?
Sir, I think it's fibers of vibration and touch. B
What are,
fibers.
so B for big, if you forget, B for beta, A beta fibers. Okay, so it will inhibit A delta
Okay, sir.
fibers. So that is, I think the answer, it applies mostly to in this question, it applies mostly to nociceptive pain, or it is also for neuropathic pain. It is the basis of how transcutaneous machine work. Supraspinal input is required. So inhibition, let's see the answer. So TENS.
Oh,
Okay.
sir, B.
Because this it has some in neuropathic pain as well, as we discussed. Okay. And then supraspinal input is not mandatory. Inhibition occurs via a beta fiber, not a delta fiber. This theory does not apply to children. No, it also apply to children. So, so that is how exactly it occurs. So, uh, C fibers and A alpha fibers. So this is blocking the gate. Okay. So the gate control theory was what this stated that pain synapses are affected by other neural inputs and inhibitory signals may prevent nociceptive impulses passing to the CNS. This applies to all pain. This is a basis of TENS and spinal cord stimulation work also. Uh, it does not explain all pain phenomena, and other theories such as neurometric theory exist. I don't know. This hypothesizes that the brain has a map of body and disruption of peripheral input may be represented as pain. Supraspinal input is not always required, and an example is the use of localized heat and light touch causing A beta fiber impulses to inhibit pain. Okay. A delta have thin myelinated axons that are responsible for transmission of thermal and pressure signals as well as mediating fast pain signals. Uh, I have not read about this thing neurometrics theory. We can have a look. What is this neurometrics theory? Pain is produced by pattern of nerve impulses from a neural network in the brain as known as body self neurometrics. Each person has their own distinct neurometrics created through genetics and modified over time through sensory experience and memory. Essentially, the CNS, including the brain and spinal cord, works together to create the experience of pain in response to stimuli from body and environment. The brain and spinal cord are the pain generators, not the peripheral nervous system or tissue damage. It explains how various parts of CNS work together to create the experience of pain. Actually, I will tell you one thing and we will finish here. There are so many things which are explained by medical science, but believe me, the phenomena which are related to brain, a number of times they are not fully explained up till now, even though we have gone so much advanced. So we don't know what is sleep. Exactly, we don't know what is sleep. Exactly how this psychiatric problem and neurological problems occur. Exactly, nobody knows. So this is what is you can say that we should be thinking like yesterday when I was trying to explain this fetal circulation. I did not read. I don't know how it just closed my mind and I was not able to explain. And today I did not. I was just thinking what happened. Why I was not able to tell because sometimes this is just a message for all of us that if God, Allah doesn't want us to do anything, our mind, our brain, everything will be closed. Okay. So this is what is we should be thankful to Allah for all the blessings which we receive from Him. Okay. So thank you very much. Actually, when I come and I try to start this class, after waking up sometime my GCS becomes very low. So anyways, I'm just trying to continue it for as much time as possible. So thank you all of you. And I will suggest you that if any points miss, please do. Uh, you can give me feedback and also if you want to add something right now, you can add anything. But this is how you should learn. Okay. Like don't read only the explanation even. Try to explore all the words. Okay. Like I was not very sure what does it mean by supraspinal input? What was this neuromatrix pain model? So that's how you can learn from the words. Actually, these books are excellent. And who says that this is for all the MCQs? This is for Viva. These are the things which are asked in the Viva as well. Okay. So thank you very much, and inshallah we will continue. Bye bye.
Thank you so much, sir.
Thank you, sir.